Lewis's Medical Surgical Nursing, 11th edition, Chapter 64, Arthritis and Connective Tissue Diseases. This chapter discusses rheumatic diseases, which primarily affect body joints, tendons, ligaments, muscles, and bones. These diseases are often marked by inflammation, pain, and loss of function in one or more of the body's connecting or supporting structures. The patient may be challenged by problems of limited function and fatigue, loss of self-esteem, altered body image, and fear of disability. More than 100 kinds of rheumatic diseases have been identified. Over 54 million people in the United States have rheumatic conditions. Arthritis. Arthritis involves inflammation of a joint or joints. Most forms of arthritis affect women more often than men in every age group. Osteoarthritis is the most common chronic condition of the joints. Other forms include rheumatoid arthritis, RA, fibromyalgia, systemic lupus erythematosus, SLE, and gout. Osteoarthritis. Osteoarthritis, OA, is a slowly progressive, non-inflammatory disorder of the diarthroidal synovial joints. Currently, OA affects 30 million Americans. This number is expected to greatly increase as the population ages. Etiology and pathophysiology. OA involves the gradual loss of articular cartilage with formation of bony outgrowths, spurs, or osteophytes, at the joint margins. OA is not a normal part of the aging process, but aging is one risk factor for disease development. Cartilage destruction likely begins between ages 20 and 30. Most adults are affected by age 40. Few patients have symptoms until after age 50 or 60. More than half of those over age 65 have X-ray evidence of OA in at least one joint. OA may be caused by a known event or condition that directly damages cartilage or causes joint instability. However, we cannot identify a single cause for many persons with OA. In these situations, various genetic traits may contribute to the development of cartilage defects. People with hand OA are more likely to develop knee OA. Decreased estrogen at menopause may contribute to the increased incidence of OA in aging women. Obesity is a modifiable risk factor that contributes to hip and knee OA. It increases mechanical stress on the joints. Regular moderate exercise, which helps with weight management, decreases the risk for disease development and progression. Anterior cruciate ligament injury from quick stops and pivoting, as in football and soccer, are linked to an increased risk for knee OA. Work that requires frequent kneeling and stooping also increase the risk for knee OA. Gender differences. The development of OA is complex. Genetic, metabolic, and local factors interact to cause cartilage deterioration from damage at the level of the chondrocytes. The normally smooth, white, translucent articular cartilage becomes dull yellow and granular as the disease progresses. Affected cartilage steadily becomes softer and less elastic. It is less able to resist wear with heavy use. The body's attempts at cartilage repair cannot keep up with the destruction of OA. As the collagen structure in the cartilage changes, articular surfaces become cracked and worn. While central cartilage becomes thinner, cartilage at the joint edges becomes thicker and osteocytes form. Joint surfaces become uneven, affecting the distribution of stress across the joint and causing reduced motion. Although inflammation is not typical of OA, secondary synovitis may occur when phagocytes try to rid the joint of small pieces of cartilage torn from the joint surfaces. These changes cause the early pain and stiffness of OA. Pain in later disease occurs when articular cartilage is lost and bony joint surfaces rub each other. Clinical manifestations. Joints. Manifestations range from mild discomfort to significant disability. Joint pain is the main symptom and the typical reason the patient seeks medical attention. Pain generally gets worse with joint use. In early stages of OA, joint pain is relieved by rest. However, the patient with advanced disease may have pain at rest or have trouble sleeping due to increased joint pain. Pain may worsen as the barometric pressure falls before the onset of severe weather. As OA progresses, increasing pain can contribute greatly to disability and loss of function. The pain of OA may be referred to the groin, buttock, or outside of the thigh or knee. Sitting down becomes hard, as does rising from a chair when the hips are lower than the knees. As OA develops in the intervertebral apophyseal joints of the spine, local pain and stiffness are common. Unlike pain, which typically worsens with activity, joint stiffness occurs after periods of rest or an unchanged position. Early morning stiffness is common. It generally resolves within 30 minutes. This distinguishes OA from inflammatory joint disorders such as RA. Overactivity can cause a mild joint swelling that temporarily increases stiffness. Crepitation, a grating sensation caused by loose cartilage particles in the joint cavity, can cause stiffness. Crepitation is common in patients with knee OA. OA usually affects joints on one side of the body, asymmetrically, rather than in pairs. For example, the left knee may be attached and the right knee unchanged. The distal interphalangeal dip and proximal interphalangeal PIP joints of the fingers and the metacarpophalangeal MCP joint of the thumb are often affected. Weight-bearing joints, hips, knees, the metatarsophalangeal MTP joint of the foot, and the cervical and lower lumbar vertebrae are often involved. Deformity. Deformity or instability associated with OA is specific to the involved joint. For example, Heberden's nodes occur on the DIP joints due to osteophyte formation and loss of joint space. They can appear as early as age 40 and tend to be seen in family members. Bouchard's nodes on the PIP joints indicate similar disease involvement. Heberden's and Bouchard's nodes are often red, swollen, and tender. Although they usually do not cause significant loss of function, the visible deformity may bother the patient. Knee OA often leads to obvious joint deformity due to cartilage loss in one joint compartment. For example, the patient becomes bow-legged, varus deformity, in response to medial joint arthritis. Lateral joint arthritis causes a knock-kneed appearance, valgus deformity. In advanced hip OA, one leg may become shorter as the joint space narrows. Systemic. Fatigue, fever, and organ involvement are not present in OA. This is an important distinction between OA and inflammatory joint disorders, such as rheumatoid arthritis. Diagnostic studies. A bone scan, CT scan, or MRI may be used to diagnose OA. These tests can detect early joint changes. X-rays help confirm disease and stage joint damage. As OA progresses, X-rays often show joint space narrowing and increasingly dense bone. Osteophytes may be visible. However, these changes do not always reflect the degree of pain the patient has. Despite strong X-ray evidence of disease, the patient may be relatively free of symptoms. Another patient may have severe pain with only slight X-ray changes. No laboratory tests or biomarkers can be used to diagnose OA. The erythrocyte sedimentation rate, ESR, is normal except for slight increases during acute inflammation. Other routine blood tests, e.g. CBC, renal, and liver function tests, are useful only in screening for related conditions or for establishing baseline values before starting treatment. Synovial fluid analysis helps distinguish OA from other types of inflammatory arthritis. In OA, the fluid is clear, yellow, with little or no sign of inflammation. Interprofessional care. OA has no cure. Interprofessional care focuses on managing pain and inflammation, preventing disability, and maintaining and improving joint function. Non-drug interventions are the basis of OA management. They should be maintained throughout the patient's treatment. Drug therapy supplements non-drug treatments. Rest and joint protection. Teach the patient with OA to balance rest and activity. Encourage rest of the affected joint during periods of acute inflammation. Keep joints in a functional position with splints or braces if needed. Avoid immobilization for more than 1 week because of the risk for joint stiffness with inactivity. Review how to modify usual activities to decrease stress on the affected joints. Teach the patient with knee OA to avoid standing, kneeling, or squatting for long periods. Using an assistive device such as a cane, walker, or crutches can decrease joint stress. Heat and cold applications. Apply heat and cold to help reduce pain and stiffness. Ice is not used as often as heat in OA treatment. Ice can be helpful if the patient has acute inflammation. Heat therapy is especially useful for stiffness. Treatments include hot packs, whirlpool baths, ultrasound, and paraffin wax baths. Nutritional therapy and exercise. If the patient is overweight, a weight reduction program is a critical part of the treatment plan. Help the patient evaluate the current diet to make needed changes. Since mobilizing the joint preserves articular cartilage health, exercise is an important part of OA management. Aerobic conditioning, range of motion, ROM exercises, and programs to strengthen muscles around the affected joint help many patients. Complementary and alternative therapies. Complementary and alternative therapies for OA symptom management are popular with patients who have not found relief through traditional medical care. Teach the patient to carefully research any alternative therapies and avoid replacing conventional OA treatments with unproven complementary approaches. Acupuncture, massage, and Tai Chi may reduce arthritis pain and improve joint mobility. Some nutritional supplements may have anti-inflammatory effects, e.g. fish oil, ginger, SAM-E. However, results of studies on glucosamine and chondroitin are mixed. The American College of Rheumatology, ACR, and American Academy of Orthopedic Surgeons, AAOS, does not recommend their use. Teach patients to discuss any supplement use with their HCP to identify possible interactions with prescribed medications. Drug therapy. Drug therapy is based on the severity of the patient's symptoms. A patient with mild to moderate joint pain may get relief from Tylenol. A topical agent, such as capsaicin cream, may be helpful, alone or with acetaminophen. It blocks pain by locally interfering with substance P. It is responsible for the transmission of pain impulses. A concentrated product is available by prescription. Creams of 0.025% to 0.075% capsaicin are available over the counter. OTC products that contain camphor, eucalyptus oil, and menthol, e.g. Bengay, Arthritis, may provide temporary relief. Topical salicylates, e.g. Aspercreme, may be an option for patients who cannot take aspirin-containing medication. Several applications may be needed daily because topical agents have short-acting effects. The patient does not get adequate pain management with acetaminophen, has moderate to severe OA pain, or has signs of joint inflammation, an NSAID drug may be more effective. NSAID therapy typically is started in low-dose OTC strengths, e.g. ibuprofen, 200 milligrams up to 4 times daily. Dose may be increased if needed. The patient is at risk for or develops GI side effects with an NSAID. Adding a protective agent, such as misoprostol cytotec, may be needed. Arthritis, a combination of misoprostol and the NSAID diclofenac, is available. A clofenac gel may be applied to the affected joint. Teach the patient who is taking oral NSAID to avoid use of a topical NSAID because of increased risk of adverse effects. All NSAIDs inhibit the production of cyclooxygenase 1, COX-1, and cyclooxygenase 2, COX-2. These enzymes convert arachidonic acid into prostaglandins. Inhibiting COX-1 causes many of the untoward effects of NSAIDs, including the risk for bleeding and GI irritation. Patients taking an anticoagulant, e.g. warfarin, Coumadin, and an NSAID are at high risk for bleeding. Long-term NSAID treatment may affect cartilage metabolism, especially in older patients who may have poor cartilage integrity. As an alternative to traditional NSAIDs, the COX-2 inhibitor celecoxib, Celebrex, may be considered in selected patients. When given in equivalent doses, all NSAIDs are comparably effective, but vary widely in cost. Individual responses to NSAIDs also vary. Some patients still prefer aspirin, but it is no longer a common treatment. It should be used cautiously with NSAIDs because both inhibit platelet function and prolong bleeding time. Intra-articular injections of corticosteroids may be needed for those with local inflammation and swelling. 4 or more injections without relief suggests the need for more intervention. Systemic corticosteroids are not used as they may actually hasten the disease process. Injection of hyaluronic acid, viscosupplementation, has been a common treatment for knee OA. However, its effectiveness is not clear. Neither the ACR nor the AAOS recommends against using hyaluronates. Research on the long-term effects continues. Drugs thought to slow the progression of OA or support joint healing are known as disease-modifying osteoarthritis drugs, DMOADs. To date, no drugs have been approved to modify OA progression, despite many clinical trials. Strontium ranelate, an approved treatment for osteoporosis, is being researched for effects on OA because it reduces levels of a cartilage turnover marker, may be helpful in OA treatment. Surgical therapy. Symptoms of disease are often managed conservatively for many years. However, the patient's loss of joint function, unmanaged pain, and decreased independence in self-care may lead to consideration of surgery. Patients with knee OA used to undergo arthroscopy to remove loose bodies from the joint. However, it does not have any benefit over physical therapy and medical treatment. Nursing management, osteoarthritis. Nursing assessment. Carefully assess and document the type, location, severity, frequency, and duration of the pain's joint pain and stiffness. Determine what makes the pain better or worse. Ask the patient how these symptoms affect the ability to perform activities of daily living. Review the patient's pain management practices. Ask about success of each treatment. Assess tenderness, swelling, limitation of movement, and crepitation of affected joints. Compare an involved joint with the opposite joint if it is not affected. Nursing diagnoses. Acute and chronic pain, impaired physical mobility, difficulty coping. Planning. Overall goals. 1. Maintain or improve joint function through a balance of rest and activity. 2. Use joint protection measures to improve activity tolerance. 3. Achieve independence and self-care and maintain optimal role function. 4. Use drug and non-drug strategies to manage pain satisfactorily. Nursing implementation. Health promotion. Prevention of OA is possible in some cases. Focus community education on altering modifiable risk factors. For example, encourage the patient to lose weight and reduce occupational or recreational hazards. For athletic instruction and physical fitness programs, include safety measures that protect and reduce trauma to the joints. Prompt treatment of traumatic joint injuries decreases the risk for OA. Acute care. The patient with OA usually is treated as an outpatient. The interprofessional team involved may include an internal medicine physician or family HCP, a rheumatologist, a nurse, an occupational therapist, and a physical therapist. Health assessment questionnaires can pinpoint areas of decreased function. They are completed at regular intervals to document disease and treatment progression. Treatment goals can be based on data from the questionnaires and physical examination, with specific interventions for identified problems. The patient is usually hospitalized only if having joint surgery. Drugs are given for the treatment of pain and inflammation. Non-drug strategies to decrease pain and disability may include massage, use of heat, thermal packs, or cold, ice packs, meditation, and yoga. Splints may be prescribed to rest and stabilize painful or inflamed joints. Once an acute flare has subsided, a physical therapist can give valuable assistance in planning an exercise program. Therapists may recommend Tai Chi as a low-impact form of exercise. Tai Chi can be done by patients of all ages and may be done in a wheelchair. Stress the importance of warming up before any exercise to decrease risk for injury. Patient and caregiver teaching related to OA is an important nursing responsibility. Provide information about the nature and treatment of the disease, pain management, body mechanics, correct use of assistive devices, e.g. cane walker, principles of joint protection and energy conservation, nutritional choices, weight and stress management, and an exercise program. Assure the patient that OA is a localized disease and severe deforming arthritis is not the usual course. The patient may gain support and understanding of the disease process through community resources such as the Arthritis Foundation Self-Help course. Ambulatory care. Adjust home management goals to meet the patient's needs. Include the caregiver, family members, and significant others in goal setting and teaching. Discuss home and work environment modification for patient safety, accessibility, and self-care. Measures include removing throw rugs, placing rails at the stairs and bathtub, using night lights, and wearing well-fitting supportive shoes. Assistive devices such as canes, walkers, elevated toilet seats, and grab bars reduce the load on an affected joint and promote safety. Urge the patient to continue all prescribed therapies at home and be open to new approaches to symptom management. Sexual counseling may help the patient and significant other to enjoy physical closeness by introducing the idea of alternative positions and timing for sexual activity. Discussion also increases awareness of each partner's needs. Encourage the patient to take analgesics or a warm bath to decrease joint stiffness before sexual activity. The expected outcomes are have adequate rest and activity, achieve acceptable pain management, maintain joint flexibility and muscle strength through joint protection and therapeutic exercise. Rheumatoid arthritis. RA is a chronic, systemic autoimmune disease characterized by inflammation of connective tissue in the diarthrodial synovial joints. RA is typically marked by periods of remission and exacerbation. RA often has extra-articular manifestations. RA has long been considered one of the most disabling forms of arthritis. Symptoms and outcomes can vary greatly. Without adequate treatment, patients may need mobility aids or joint reconstruction. They may have loss of independence and self-care ability. RA occurs globally, affecting all ethnic groups. It can occur at any time of life. However, incidence increases with age, peaking between ages 30 and 50 years. RA affects around 1.5 million adult Americans. Almost 3 times as many women have the disease as men. Etiology and pathophysiology. We do not know the exact cause of RA. It likely results from a combination of genetics and environmental triggers. An autoimmune cause is currently the most widely accepted theory. This theory suggests changes of RA begin when a genetically susceptible person has an initial immune response to an antigen. Although a bacterium or virus could be the possible antigen, no infection or organism has been found to date. The antigen, which is probably not the same in all patients, triggers formation of an abnormal immunoglobulin G, IgG. RA is marked by autoantibodies to this abnormal IgG. The autoantibodies are known as rheumatoid factor. They combine with IgG to form immune complexes that initially deposit on synovial membranes or superficial articular cartilage in the joints. Immune complex formation leads to the activation of complement and an inflammatory response. Neutrophils are attracted to the site of inflammation, where they release proteolytic enzymes that damage articular cartilage and cause the synovial lining to thicken. Other inflammatory cells include T helper CD4 cells, which stimulate cell-mediated immune responses. Activated CD4 cells cause monocytes, macrophages, and synovial fibroblasts to secrete the pro-inflammatory cytokines interleukin-1, IL-1, IL-6, and tumor necrosis factor, TNF. These cytokines drive the inflammatory response in RA. Some patients report a precipitating stressful event, such as infection, work stress, physical exertion, childbirth, surgery, or emotional upset. However, research has been unable to directly correlate such events. RA onset. Genetic link. Genetic predisposition is important in the development of RA. Strongest evidence for a genetic influence is the role of human leukocyte antigens, HLA, especially the HLA-DR4 and HLA-DR1 antigens. Smoking increases the risk for RA for persons who are genetically predisposed to the disease. It may interfere with treatment for diagnosed persons. Clinical manifestations. Joints. The onset of RA is typically subtle. Nonspecific manifestations such as fatigue, anorexia, weight loss, and generalized stiffness may precede the onset of joint symptoms. Stiffness becomes more localized in the following weeks to months. Specific joint involvement is marked by pain, stiffness, limited motion, and signs of inflammation, e.g. heat, swelling, tenderness. Joint symptoms occur symmetrically and often affect the small joints of the hands, PIP and MCP, and feet, MTP. Larger peripheral joints such as wrists, elbows, shoulders, knees, hips, ankles, and jaw may be involved. The cervical spine may be affected, but the axial skeleton, spine, and bones connected to it is generally spared. The patient typically has joint stiffness after periods of inactivity. Morning stiffness may last from 60 minutes to several hours or more, depending on disease activity. MCP and PIP joints are typically swollen. In early disease, fingers may become spindle-shaped from synovial hypertrophy and thickening of the joint capsule. Joints are tender, painful, and warm to the touch. Joint pain increases with motion. It varies in intensity. It may not be related to the degree of inflammation. Tenosynovitis often affects the extensor and flexor tendons around the wrists. This causes symptoms of carpal tunnel syndrome, makes it hard for the patient to grasp objects. As the disease progresses, inflammation and fibrosis of the joint capsule and supporting structures may cause deformity and disability. Muscle atrophy and tendon destruction cause one joint surface to slip past the other, subluxation. Metatarsal head dislocation and subluxation in the feet may cause pain and walking disability. Ulnar drift, zigzag deformity, swan neck, and boutonniere deformities are common in the hands. Extra-articular manifestations. RA can affect nearly every body system. Extra-articular manifestations are more likely to occur in the person with high levels of biomarkers, such as RF, Rheumatoid nodules develop in about half the patients with RA. Rheumatoid nodules appear under the skin as firm, non-tender masses. They are often found on bony areas exposed to pressure, such as the fingers and elbows. Nodules at the base of the spine and back of the head are common in older adults. Treatment is usually not needed. However, these nodules can break down like pressure injuries. Cataracts and vision loss can result from scleral nodules. Nodular myositis and muscle fiber degeneration can cause pain like that of vascular insufficiency. In later disease, nodules in the heart and lung can cause pleurisy, pleural effusion, pericarditis, pericardial effusion, and cardiomyopathy. Sjogren's syndrome can occur by itself or with other arthritic disorders such as RA and SLE. The inflammation of RA can damage the tear-producing lacrimal glands, making the eyes feel dry and gritty. Affected patients may have photosensitivity. Felty syndrome is rare, but can occur in those with long-standing RA. It is characterized by an enlarged spleen and low white blood cell count. Patients with Felty syndrome are at increased risk for infection and lymphoma. Flexion contractures and hand deformities cause decreased grasp strength and affect the patient's ability to perform self-care tasks. Depression may occur. However, it is unclear if the patient becomes depressed from struggling with chronic pain and disability, or if depression is part of the autoimmune disease process. Levels of C-reactive protein, CRP, a marker of inflammation, are higher in patients with depression compared to those with no symptoms of depression. Diagnostic studies. Accurate diagnosis is critical to prompt initiation of treatment to decrease the risk for disability. A diagnosis is often made based on history and physical findings. Laboratory tests are used to confirm diagnosis and monitor disease progression. Positive RF occurs in 80% of adults with RA. Titers rise during active disease. ESR and CRP are increased as general indicators of active inflammation. Testing for the antibodies to citrullinated peptide, anti-CCP, is more specific than RF for RA. Anti-CCP is present in 60 to 80% of patients with RA. It can be found in patients' blood 5 to 10 years before they have symptoms of RA. If the patient's symptoms are consistent with RA, the presence of anti-CCP and RF makes a strong case for early, accurate diagnosis. An increase in anti-nuclear antibody ANA titers is an indicator of autoimmune reaction. Synovial fluid analysis in early disease often shows slightly cloudy, straw-colored fluid with many fibrin flecks. The enzyme MMP3 is increased in the synovial fluid. It may be a marker of progressive joint damage. The WBC count of synovial fluid is increased. Tissue biopsy can confirm inflammatory changes in the synovial membrane. X-rays alone are not diagnostic of RA. It may show only soft tissue swelling and possible bone demineralization in early disease. A narrow joint space articular cartilage destruction, erosion, subluxation, and deformity are seen in later disease. Poor alignment and fusion may be seen in advanced disease. Baseline X-rays may be used to monitor disease progression and treatment effectiveness. Bone scans are more useful in detecting early joint changes and confirming diagnosis so that RA treatment can be started. Interprofessional care. An individualized treatment plan considers disease activity, joint function, age, sex, family, and social roles in response to previous treatment. Treatment advances have improved the prognosis for patients with newly diagnosed RA. The progression of joint damage can be slowed or stopped with aggressive early treatment. A caring, long-term relationship with an interprofessional healthcare team can promote the patient's self-esteem and positive coping. Drug therapy. Disease-modifying anti-rheumatic drugs. Drugs are the cornerstone of RA treatment. Because irreversible joint changes can occur as early as the first year of RA, HCPs aggressively prescribe disease-modifying anti-rheumatic drugs, DMARDs. These drugs may slow disease progression and decrease risk for joint erosion and deformity. The choice of drug is based on disease activity, patient's functional level, and lifestyle considerations, such as the wish to become pregnant. Methotrexate is preferred for early treatment of patients diagnosed with RA. It has a lower risk for toxicity than other drugs. Rare but serious side effects include bone marrow suppression and hepatotoxicity. Methotrexate therapy requires frequent laboratory monitoring, including CBC and blood chemistry. Patient begins to see therapeutic effects within 4 to 6 weeks. However, not everyone gets adequate relief from methotrexate alone. Be given with other DMARDs or biologic response modifiers. Sulfasaline, azulfidine, and the anti-malarial drug hydroxychloroquine, Plaquenil, may be effective DMARDs for mild to moderate disease. They are rapidly absorbed, relatively safe, and well tolerated. Teach the patient taking sulfasalazine to drink adequate fluids to avoid crystal formation in the urine. Urge the patient to wear sunscreen with sun exposure. For those taking hydroxychloroquine, a baseline eye examination, follow-up every 6 to 12 months is needed because of the risk for vision loss. The synthetic DMARD leflunomide, Arava, blocks immune cell overproduction. Its efficacy and side effects are similar to those of methotrexate and sulfasalazine. Because the drug is teratogenic, pregnancy in women of childbearing age must be excluded before therapy is started. Using 2 kinds of birth control is recommended during treatment. Tofacitinib Xeljanz, a JAK Janus kinase inhibitor, is used to treat moderate to severe active RA. The drug interferes with JAK enzymes that contribute to joint inflammation in RA. Live vaccinations should not be given to the patient receiving tofacitinib. Biologic response modifiers. Biologic response modifiers, BRMs, also called biologics or immunotherapy, are used to slow disease progression in RA. BRMs are classified based on their mechanism of action. They can be used to treat patients with moderate to severe RA who have not responded to DMARDs. They can be used alone or in combination therapy with a DMARD such as methotrexate. TNF inhibitors include etanercept, Enbrel, infliximab, Remicade, adalimumab, Humira, certolizumab, Cimzia, and golimumab, Simponi. Etanercept is a biologically engineered copy of the TNF cell receptor. It binds to TNF in circulation before TNF can bind to the cell surface receptor. Thus, it inhibits the inflammatory response. This drug is given as a subcutaneous injection. Infliximab and adalimumab are monoclonal antibodies that bind to TNF, preventing it from binding to TNF receptors on cells. Infliximab is given IV in combination with methotrexate. Adalimumab is given subcutaneously. Certolizumab and golimumab are TNF inhibitors that improve symptoms in patients with moderate to severe RA. Both drugs are given in combination with methotrexate. Anakinra, Kineret, is an IL-1 receptor antagonist, IL-1RA, created from new combinations of genetic material. It blocks the biologic activity of IL-1 by competitively inhibiting its ability to bind to the IL-1 receptor. Anakinra is given as a subcutaneous injection. It is used to reduce pain and swelling of moderate to severe RA. It can be used in combination with DMARDs, but not with other TNF inhibitors. Using these agents together can lead to serious infection and neutropenia. Tocilizumab, Actemra, and sarilumab Kevzara block the action of IL-6, a cytokine that contributes to inflammation. They are used to treat patients with moderate to severe RA who have not responded to or cannot tolerate other drugs for the disease. Abatacept, or Encia, blocks T-cell activation. It is recommended for patients who have inadequate response to DMARDs or TNF inhibitors. It is given IV. Like anakinra, should not be used with TNF inhibitors. Rituximab, Rituxan, is a monoclonal antibody that targets B cells. It may be used in combination with methotrexate for patients with moderate to severe RA not responding to TNF inhibitors. It is given IV. Other drug therapy. Other DMARDs include immunosuppressants, azathioprine, penicillamine, cuprimine, and gold preparations. These medications are used less often because they are weak treatments compared to other DMARDs and biologics. Corticosteroid therapy can be used to manage symptoms during disease flares. Intra-articular injections may temporarily reduce acute pain and inflammation. Low-dose oral corticosteroids may be used for a limited time to decrease disease activity till the effects of DMARDs or biologics are seen. However, they are inadequate as a sole therapy because they do not affect disease progression. Their long-term use should not be a mainstay of RA treatment. Complications include osteoporosis and avascular necrosis. Various NSAIDs and salicylates are used to treat arthritis, pain, and inflammation. Aspirin may be used in dosages of 3 to 4 grams per day in 3 to 4 doses. Blood salicylate levels should be monitored. The patient taking more than 3,600 milligrams daily. NSAIDs have anti-inflammatory and analgesic effects. Some relief may be seen within days of starting treatment with NSAIDs. Full effect may take 2 to 3 weeks. NSAIDs may be used when the patient cannot tolerate aspirin. The patient may be able to better follow the treatment plan if using an anti-inflammatory drug that can be taken only once or twice a day. Celecoxib, Celebrex, the only available COX-2 inhibitor, is effective in RA as well as OA. All non-aspirin NSAIDs can increase the risk for blood clots, heart attack, and stroke. Nutritional therapy. Although no special diet is needed for RA, balanced nutrition is important. Fatigue, pain, and depression may cause a loss of appetite. Limited endurance and mobility may make it hard to shop for and prepare food. Weight loss may result. The occupational therapist can help the patient modify the home environment and use assistive devices for easier food preparation. Corticosteroid therapy and decreased mobility due to pain may cause unwanted weight gain. Corticosteroids increase the appetite, leading to higher caloric intake. A sensible weight loss program with balanced nutrition and exercise reduces stress on affected joints. The patient taking corticosteroids may become distressed as signs and symptoms of Cushing syndrome, e.g. moon face, redistribution of fatty tissues to the trunk, change the physical appearance. Encourage the patient not to change the dose or stop therapy abruptly. Weight will return to normal several months after treatment ends. Remind the patient to continue to eat a balanced diet. Surgical therapy. Surgery may be needed to relieve severe pain and improve the function of severely deformed joints. Removal of the joint lining, synovectomy, is one type of surgery. Total joint replacement, arthroplasty, can be done for many different joints in the body. Joint surgery is discussed in Chapter 62. Nursing management, rheumatoid arthritis. Nursing assessment. Subjective and objective data, blah, blah, blah. Begin with a careful physical assessment, e.g. joint pain, swelling, ROM, general health status. Assess psychosocial needs, e.g. family support, sexual satisfaction, emotional stress, financial constraints, vocational and career limitations. Assess for environmental concerns, e.g. transportation, home or work modifications. After identifying the patient's problems, carefully plan a program for rehabilitation and education with the interprofessional care team. Nursing diagnoses. Impaired physical mobility, chronic pain, disturbed body image. Planning. The overall goals are that the patient with RA will 1. Have acceptable pain management, 2. Have minimal loss of function of affected joints, 3. Take part in planning and implementing the treatment plan, 4. Maintain a positive self-image, and 5. Perform self-care to maximum amount possible. Nursing implementation, health promotion. Prevention of RA is not possible. Early treatment can help prevent further joint damage. Community education programs should focus on symptom recognition to promote early diagnosis and treatment. The Arthritis Foundation offers many publications, classes, and support activities to help persons with RA. Acute care. Patient newly diagnosed with RA is usually treated on an outpatient basis. Hospitalization may be needed for the patient who has systemic complications or needs surgery for decreased functional ability. Work closely with the HCP. Physical and occupational therapists, a social worker to help the patient regain function and adjust to chronic illness. Ambulatory care. Care of the patient with RA includes A broad program of drug therapy balance of rest and activity with joint protection, use of heat and cold applications, exercise, and patient and caregiver teaching. Non-drug management may include the use of therapeutic heat and cold, rest, relaxation techniques, joint protection, biofeedback, transcutaneous electrical nerve stimulation, and hypnosis. Allow the patient and caregiver to choose therapies that promote optimal comfort and fit their lifestyle. Rest. Alternating scheduled rest periods with activity throughout the day helps relieve fatigue and pain. The amount of rest needed varies based on disease severity and the patient's limitations. Patients should rest before becoming exhausted. Total bed rest is rarely necessary. Should be avoided to prevent stiffness and other effects of immobility. Patient with mild disease may need daytime rest plus 8 to 10 hours of sleep at night. Help the patient find ways to change daily activities to avoid overexertion and fatigue, which can worsen disease activity. For example, the patient may be able to prepare meals more easily while sitting on a high stool in front of the sink. Teach the patient to maintain good body alignment during rest through use of a firm mattress or bedboard. Encourage positions of extension. Teach the patient to avoid positions of flexion. To decrease the risk for joint contracture, never place pillows under the knees. Use a small flat pillow under the head and shoulders if needed. Joint protection. Protecting joints from stress is important. Help the patient find ways to alter routine tasks to put less stress on joints. Energy conservation requires careful planning. The emphasis is on work simplification. Work for short periods with scheduled rest breaks to avoid fatigue, pacing. Organize activities to avoid going up and down stairs repeatedly. Use carts to carry supplies. Store frequently used materials in a convenient, easy to reach area. Use joint protective devices, e.g. electric can opener, whenever possible. Teach patients to delegate tasks to other family members. An occupational therapist helps the patient maintain upper extremity function and encourages use of splints or other assistive devices for joint protection. Lightweight splints may be prescribed to rest an inflamed joint and prevent deformity from muscle spasms and contractures. Remove the splints regularly to assess skin and perform ROM exercises. After assessment and supportive care, reapply splints as prescribed. Occupational therapy may increase patient independence with assistive devices that simplify tasks, e.g. built-up utensils, button hooks, modified drawer handles, lightweight plastic dishes, raised toilet seats. Encourage the patient to make dressing easier by wearing shoes with Velcro fasteners and clothing with buttons or a zipper in the front instead of the back. Use a cane or walker for support and decreased pain when walking. Cold and heat therapy and exercise. Cold and heat applications can help relieve stiffness, pain, and muscle spasm. Heat and cold can be used several times a day as needed. Ice is especially helpful during periods of increased disease activity. Cold application should not exceed 10 to 15 minutes at a time. Plastic bags of small frozen vegetables, peas, or kernel corn can easily mold around the shoulder, wrist, or knees to be effective home treatment. The patient can use ice cubes or small paper cups of frozen water to massage areas on either side of a painful joint. Moist heat offers better relief for chronic stiffness. However, heat application should not exceed 20 minutes at a time. Heating pads, moist hot packs, paraffin baths, and warm baths or showers can relieve stiffness to allow the patient to take part in therapeutic exercise. Alert the patient to the risk for a burn and the need to avoid using a heat-producing cream, e.g. capsaicin, with an external heat device. Sitting or standing in a warm shower, sitting in a tub with warm towels around the shoulders, or simply soaking the hands in a basin of warm water may relieve joint stiffness and allow the patient to perform ADLs more comfortably. Individualized exercise is an important part of the treatment plan. A physical therapist may develop a therapeutic exercise program to improve flexibility and strength of affected joints and increase the patient's endurance. Encourage program participation and reinforce correct performance of the exercises. Progressive joint immobility and muscle weakness can occur if the patient does not move the joints. Over-aggressive exercise can cause increased pain, inflammation, and joint damage. Emphasize that taking part in a recreational exercise program, e.g. walking, swimming, or doing usual daily activities does not take the place of therapeutic exercise to maintain adequate joint motion. Gentle ROM exercises are usually done daily to keep joints functional. The patient should practice exercises with supervision. Exercising in warm water, 78 to 86 degrees Fahrenheit, allows easier joint movement because of the buoyancy and warmth of the water. Although movement seems easier, water provides two-way resistance that makes muscles work harder than they would on land. During acute inflammation, limit exercise to 1 or 2 reps. Patient and caregiver teaching. Care of the patient with RA begins with a thorough program of education and drug therapy. Teach the patient and caregiver about the disease process and home management strategies. Inflammation may be managed through administration of NSAIDs, DMARDs, and BRMs. Careful timing of drug administration is critical to maintain a therapeutic drug level and reduce early morning stiffness. Discuss the action and side effects of each prescribed drug and any needed laboratory monitoring. Many patients with RA take several different drugs, so make the drug regimen as understandable as possible. Encourage patients to develop a way to remember to take their medications, e.g. pill containers. Psychologic support. For effective self-management and adherence to an individualized home treatment program, help the patient understand the nature and course of RA and the goals of therapy. Consider the patient's value system and perception of the disease. Discuss changes in sexuality. Chronic pain or loss of function may make the patient vulnerable to claims of false advertising about unproven or even dangerous remedies. Help the patient recognize fears and concerns faced by all people who live with chronic illness. Evaluate the family support system. Financial planning may be needed. Consider community resources such as home care nurse, homemaker services, and vocational rehabilitation. Self-help groups are helpful for some patients. Living with chronic pain may lead to depression. To decrease depressive symptoms, suggest activities such as listening to music, reading, exercising, and counseling. Hypnosis and biofeedback may be useful. Gerontologic considerations. Arthritis. The prevalence of arthritis in older adults is high. The disease is accompanied by problems unique to this age group. Areas of concern for older adults include the high incidence of OA in older adults may keep the HCP from considering other types of arthritis. Age alone causes changes that make interpretation of laboratory values such as RF and ESR more difficult. Drugs taken for comorbid conditions can affect laboratory values. Musculoskeletal pain syndromes and weakness may have no physical cause. Instead, they may be related to depression and physical inactivity. Diseases such as SLE, which often occur in younger adults, can develop in a milder form in older adults. Physical and metabolic changes of aging may increase the older patient's sensitivity to both therapeutic and toxic effects of some drugs. The older adult who takes NSAIDs has an increased risk for side effects, especially GI bleeding and renal toxicity. Using NSAIDs with a shorter half-life may need more frequent dosing and have fewer side effects in the older patient with altered drug metabolism. Polypharmacy in the older adult is a concern. Use of drugs in RA treatment may increase the chance of unexpected drug interactions. The drug regimen should be as simple as possible to increase adherence, e.g. limited number of drugs with increased frequency of administration. This is especially important for those who lack regular assistance. Osteopenia from corticosteroid use can worsen the problem of decreased bone density from aging and inactivity. The risk for pathologic fractures is increased, especially vertebral compression fractures. Myopathy related to corticosteroid use can be minimized by an age-appropriate exercise program. An adequate support system for the older adult is critical to the ability to follow a treatment plan. Gout. Gout is a type of arthritis characterized by elevation of uric acid, hyperuricemia, and the deposit of uric acid crystals in one or more joints. Sodium urate crystals can be found in articular, periarticular, and subcutaneous tissues. Unlike other forms of arthritis, gout is marked by painful flares lasting days to weeks, followed by long periods without symptoms. More than 8 million Americans have gout. Blacks have a higher incidence compared to whites. Etiology and pathophysiology. Uric acid is the major end product of purine catabolism. It's primarily excreted by the kidneys. Gout occurs when either the kidneys cannot excrete enough uric acid or there is too much being made for the kidneys to handle effectively. We classify hyperuricemia as primary or secondary. Primary hyperuricemia is genetic. A hereditary error of purine metabolism leads to the overproduction of or retention of uric acid. Secondary hyperuricemia may be caused by conditions that increase uric acid production or decrease uric acid excretion, or drugs that inhibit uric acid excretion, e.g. loop diuretics, beta blockers. Organ transplant recipients receiving immunosuppressive agents are at risk for hyperuricemia. Gout is likely caused by the interaction of several factors. Most important is metabolic syndrome, obesity, insulin resistance, hypertension, hyperlipidemia. Increased intake of foods containing purines, e.g. red and organ meat, shellfish, fructose drinks, can trigger gout. High uric acid may result from prolonged fasting or excessive alcohol use because they increase the production of keto acids, which inhibit uric acid excretion. Not everyone with high uric acid levels develops gout. Two processes are essential for a person to develop gout: crystallization and inflammation. As urate levels increase and saturate the synovial fluid or soft tissues, the excess urate coalesces into crystals. These trigger inflammation. Monocytes and macrophages try to remove the crystals through phagocytosis. This causes the release of inflammatory mediators into the surrounding area, causing more inflammation and tissue damage. Clinical manifestations and complications. Gout may occur acutely in one or more joints, usually less than 4. Inflammation of the great toe, podagra, is the most common initial problem. Other affected joints include wrists, knees, ankles, and the midfoot. Olecranon bursae may be involved. Affected joints may appear dusky or cyanotic and are extremely tender. Acute gout arthritis is usually triggered by events such as trauma, surgery, alcohol use, or systemic infection. Symptom onset typically occurs at night with sudden swelling and severe pain peaking within several hours. The painful area is highly sensitive to light touch. Low-grade fever is common. An attack usually ends in 2 to 10 days, with or without treatment. The affected joint returns to normal, and patients have no symptoms between attacks. Chronic gout is characterized by multiple joint involvement and visible deposits of sodium urate crystals called tophi. Tophi are hard white nodules. They are typically seen in subcutaneous tissue, synovial membranes, tendons, and soft tissues. Tophi generally occur many years after the onset of disease. The severity of gout arthritis varies. The clinical course may involve infrequent mild attacks or multiple severe episodes, up to 12 per year, marked by slowly progressive disability. In general, tophi appear earlier, and the patient has more frequent severe episodes of gout if serum uric acid is high. Chronic inflammation may cause joint deformity, and cartilage destruction may lead to secondary OA. Large urate crystal deposits may pierce overlying skin, producing draining sinuses that often become infected. Excessive uric acid excretion may lead to stone formation in the kidneys or urinary tract. Pyelonephritis related to sodium urate deposits and obstruction contributes to kidney disease. Diagnostic studies. In gout, serum uric acid is usually increased above 6 milligrams per deciliter. However, hyperuricemia is not specifically diagnostic of gout because serum values may be normal during an acute gout attack. Increased uric acid may be related to various drugs or an asymptomatic abnormality in the general population. A 24-hour urine uric acid can determine if the disease is caused by decreased renal excretion or overproduction of uric acid. The gold standard for diagnosis of gout is synovial fluid aspiration. Affected fluid contains needle-like monosodium urate crystals. This procedure is done in only a small number of patients because diagnosis can typically be made on clinical symptoms alone. However, it is the only reliable way to tell gout from septic arthritis or pseudogout, calcium phosphate crystal formation. Aspiration may decrease pain by relieving pressure in a swollen joint capsule. X-rays appear normal in the early stages of gout. In chronic disease, tophi may appear as eroded areas in the bone. Interprofessional and nursing management, gout. Goals for the care of the patient with gout include ending an acute attack with an anti-inflammatory agent such as colchicine. Hyperuricemia and gout are chronic problems that can be controlled with effective patient education and careful adherence to a treatment program. Drug therapy is the primary way to treat acute and chronic gout. Drug therapy. Acute gout is treated with oral colchicine, Colchris, Mitigare, and NSAIDs because colchicine has anti-inflammatory effects but is not an analgesic. An NSAID is added for pain management. Colchicine generally produces dramatic pain relief when given within 12 hours of an attack. This helps in diagnosis because good response to this drug is further evidence of gout. Corticosteroids, orally or by intra-articular injection, can be helpful in treating an acute attack. Systemic corticosteroids may be used only if routine therapies are contraindicated or ineffective. Adrenocorticotropic hormone, ACTH, may be used for acute treatment of patients for whom NSAIDs, colchicine, or steroids may be problematic. Future attacks of gout are prevented in part by a maintenance dose of a xanthine oxidase inhibitor. These drugs decrease the production of uric acid. Allopurinol is the most commonly used drug and the first choice for therapy. It is used for patients with uric acid kidney stones or renal impairment. Serious adverse effects limit the use of febuxostat, Uloric. The ACR recommends therapy with probenecid If allopurinol or febuxostat are contraindicated or the patient has intolerance to either. Probenecid is a uricosuric, increasing uric acid excretion in the urine. Aspirin inactivates its effect, resulting in urate retention and must be avoided during treatment. Acetaminophen can be used safely if analgesia is needed. Lesinurad, Zurampic, a new uricosuric agent, can be taken with a xanthine oxidase inhibitor for those with persistent increased uric acid levels. Duzelo, a fixed-dose combination of lesinurad and allopurinol, is taken once daily. Uricosurics can cause renal impairment. They are ineffective when creatinine clearance is reduced, as can occur in patients over age 60 years or with renal impairment. They should be taken in the morning with food and water. Teach patients to stay well hydrated and to drink about 2 liters of liquid a day when taking the drug. Patients who cannot take or do not respond to drugs that lower serum uric acid may be given pegloticase Krystexxa. This drug is an enzyme that metabolizes uric acid into a harmless chemical excreted in the urine. It is given IV, usually for at least 6 months. Life-threatening anaphylactic and infusion reactions can occur. The angiotensin II receptor antagonist losartan, Cosar, may be effective for treating older patients with gout and hypertension. Losartan promotes urate excretion and may normalize serum urate. Combination therapy with losartan and allopurinol may be used. Serum uric acid must be checked regularly to monitor treatment effectiveness. Explain the importance of drug therapy and the need for regular assessment of serum uric acid. Dietary restrictions that limit alcohol and foods high in purine help minimize uric acid production. Adequate urine volume with normal renal function, 2 to 3 liters per day, must be maintained to prevent precipitation of uric acid in the renal tubules. Teach obese patients in a carefully planned weight reduction program. Teach the patient about other factors that may cause an attack, including fasting, drug use, e.g. diuretics, and major medical events, e.g. surgery, heart attack. Nursing interventions for the patient with acute gout include supportive care of the inflamed joints. Avoid causing pain by careless handling of an inflamed joint. Bed rest may be appropriate to immobilize affected joints as needed. Use a cradle or footboard to protect a painful lower extremity from the weight of bed linens. Assess motion limitations and degree of pain. And we're going to stop there on page 1515 because that is the assignment for this unit of my particular nursing program.